Thank you so much for the very inspiring keynote speech delivered by the first two speakers, Professor Sally Chen and Professor Sandra Bussy, related to the application of digital health, technology for the mental health in elders and also in psychosis. Now, it's my absolute pleasure to introduce our first speaker, keynote speaker for you. I'm Lorna Sun, the faculty from the School of Nursing, Dong-A College. The first speaker is Professor Jacinto Barassi. Yeah, I just learned from Professor Barassi that her name is very beautiful. Actually, is a lovely plant, right? Because Professor Barassi is originally from Italy. Yeah, so it's an Italian word. So if you ever wonder what happens when you combine the world of advanced robotics with the deep mysteries of the human brain, Professor Barassi is the person with the answers. He joined us from the Bristol Robotics Laboratory in the UK. He is a professor from the University of West of England in Bristol, and he brings a truly unique perspective to the stage. He holds a PhD in robotics and a Master of Science in Psychology and Neuroscience. And so this expertise actually allows him to design technology that doesn't just work well, but actually understand the person using it. Beyond his research, he's a global leader in the field, chairing international committees on human factors and telehealth for major organizations like the Institute of Electrical and Electronics Engineers and the International Ergonomics Association. Today, he is here to help us to bridge the gap between the high-tech robotics and the heart of healthcare. So his topic is here show neuroergonomics in robotic digital system for health, bridging technology and care. Please join me in welcoming Professor Barassi. Professor Barassi, please.
Thank you very much for this wonderful presentation. Thank you very much for the opportunity of having me today. Thank you for attending this presentation. Honestly, most of the examples will be related to motor activities, but they will always be related to mental processes because as was highlighted, my background is in psychology and neuroscience, so cognition for me is the key for trying to improve the interaction with technology that are dedicated to the amelioration of our health. So, okay. I'm a professor of robotics at the Bristol Robotics Laboratory, and I work mostly on human factors, trying to improve the alignment between the machine and the users, especially in context where we are employing robots for health and safety. And I work and I serve in different communities, academic and extra-academic communities related mostly to robotics, ergonomics, and telehealth, for instance, as the chair for this domain of the telepresence initiative. And I'm also a teacher, professor in engineering context mostly, especially abroad in the University of Electronic Science and Technology of China. I had wonderful days in Chengdu, for instance, 1 year ago. And since July 2024, I work at the Bristol Robotics Laboratory, which is the biggest multidisciplinary robotics laboratory in Europe. And it's a joint initiative of the University of the West of England, where I work, and the University of Bristol. Over 13 years anyway, I worked at the Italian Institute of Technology, where I probably dedicated my activity to any type of medical robot, from the ones for surgery to rehabilitation, assistance, prosthetics, and also devices for virtual reality in this kind of application. For instance, I was the leader of the ENACT project for rehabilitation technology in multiple sclerosis, and I was also coordinating a network across the world for trying to improve the conditions of people with this type of issue, and especially for motor cognitive rehabilitation. Overall, my goal is always to try to enhance or restore abilities. These are two examples of my works related to rehabilitation and to assistance in context of where we are using exoskeletons, let's say wearable devices, wearable robots. Anyway, these devices are quite helpful, but they're not adopted so much. And according to the most recent reports, the main problem is the fact that the workforce is not able to interact with them, and the users can find difficulties. That's why the main strategies for trying to improve the adoption of robots are the training of the user or the human-centered design, trying to improve the design of the robots and the devices in order to match the expectations and the capabilities of the users. That's why I was hired initially in the IIT for working on the human-centered design of medical devices or robotic medical devices. This is an example for an exoskeleton for occupational therapy float. It was made for improving the capabilities of people just after an accident. And another part of my work was dedicated, and it's still dedicated to user research, for instance, for the co-design, in this case, of a prosthetic, of a lowering prosthetic device. Through the activity of the interaction and interviews and the collection of the needs from the users and from the clinicians, we understood, and the technicians, we understood that their needs were mostly related to the feeling of integration, the improved versatility and the reliability of the devices. Overall, all my activities fall in the remit of what we call ergonomics. My specialty is human factors and ergonomics. It's the discipline that is investigating how we interact with other elements of a system. Why other? Because we are part of the system itself. And ergonomics is a discipline that is dedicated to design solutions, not only to investigate how we work actually in a certain context. And it's an interdisciplinary domain because we need, for understanding the human skills limitation needs in real context, we need methodologies from psychology, medicine, engineering, the various types of engineering, ethics, sociology, management, and many others. This is an example of a recent study I conducted with a friend of mine from the Chinese University of Hong Kong, Fei Chen. We tried to integrate, this is just an example, my know-how in ergonomics, especially in cognitive ergonomics, how we use our mental capabilities for interacting with the device, with the expertise of Fei in human-robot collaboration in contexts that are requiring the usage of a robot, especially in manufacturing. And we defined several types of methodologies for trying to reduce the mental workload for the user. In ergonomics, there are three branches. Typically, we always think about the physical ergonomics, the one related to the physical features, like the ones related to anthropometrics and biomechanics. But there is also the cognitive ergonomics, which is my specialty, which is related to the mental processes, memory, attention, perception, learning, decision-making, and so on. And organizational ergonomics that is related to the socio-technical systems, the policies, and the teamwork overall. Why such an attention for the mental processes? Because we are made for moving human bodies according to minds and brains that actually are similar to the ones of the Paleolithic age. We didn't change so much from that time, and we are still working according to the same processes that are made for making us manipulate big objects and to keep in our mind 7 plus minus 2 items in our memory. So even if technology is able to bring us inside the larynx of a patient for operating, if our device, if our control interfaces are not made for our hands and for our attention, for our perception, we are going to make probably more damage, more harm than what we want to relate the patient of. And we are not made for being cyborgs controlling artificial limbs. This was one of the last projects I was contributing into in the IIT. It's the hyperleg project, and we were trying to create a condition for the patient to control, for the user of a prosthetic leg, to move intuitively and to avoid most of the let's say, or the deviations that typically made that are typically made by the users of these devices through the actuation of the knee and the actuation of the ankle, and with something we call like a physiological controller. So we need to make technology intuitive for avoiding to add a burden on the patient, on the user, when they want to use our devices for solving other problems. And I want to mention this anecdote. Um, in cognitive ergonomics, one of the milestones is this book of Donald Norman in 1988. He was talking about the psychology of everyday things. And anyway, in my language, in Italian, the current translation of the book is mentioning the let's say the book is named in this case after that object that is on the cover, the coffee pot for masochists. You can guess what's happening if you're trying to pour the coffee with the coffee pot. And anyway, there is a subtitle. There is that is based on the real title of the just partially of the book, "The Design of Everyday Things." Anyway, now this subtitle is shifting from the content of psychology to the one of design. But the version of the book I studied on when I was a student in psychology actually was using the term psychopathology of the everyday things, which is far better matching my perspective of our interaction with the devices, which could be not so adaptive, and it could be psychopathological sometimes. Anyway, the step I made after working on cognitive ergonomics was the one of trying to use neuroscientific methods in order to improve our capability to know in real context outside the laboratory how our brain works and how our nervous system, also the peripheral nervous system, can offer us several types of information for understanding how we interact with devices, according to the methodologies offered by neuroergonomics. We are getting using devices that are typically adopted in laboratory in real context. It could be like the one of the pilots of an airplane. As you can see, they're wearing on top of the screen the EEG cup for electroencephalography, for understanding, for instance, the level of mental workload, or understanding better the situation awareness. There could be also devices for capturing information on the eye tracking, the movement of the gaze, in order to understand how the attention is moving across the environment, or wearable devices like the empathic wristband that can give us information on the heart rate variability, which is quite rich for telling us the level of stress of the person, for instance. Why neuroergonomics? Because we need real-time information that is able to enrich our data on the user actions and reactions. And this data should be ecologically valid because it's related to what is happening in real life, in real context, not in abstract context of the laboratories. And it should be meaningful and significant. So it will be related to what is the actual meaning of our action, and statistically significant and temporally associated to specific events. This is why we use this kind of approach. And why not psychophysiology, for instance, as a term? This was a question asked by a friend of mine during a webinar at the time of the pandemic, I remember. My response was that we need something that is fully integrated with the process of the user research and user-centered design, and neuroergonomics is offering exactly this bridge between the design and the research. And neuroergonomics exactly using the neuroscientific methods to investigate and design interactions between human and system in ecologically valid and real-world context. And we can do this for assessing the interactions, so we can do this for training the users to interact with the system, and also for making a system able to adapt to the user in a smart way when, for instance, they're controlled through an AI. Simultaneously, we are getting information that can be used for increasing our neuroscientific knowledge and know-how, and we can use such a knowledge for improving our neuroergonomic methodologies. My first neuroergonomics work, just an example, was for my PhD dissertation, and it was this system for training the attention of the surgeon by connecting an electroencephalographic cup with an augmented reality scalpel, a digital scalpel that was appearing on the location where the surgeon was controlling a laser for the training. The scalpel was retracting when the surgeon was distracted according to the biosignals we were collecting. So they were forced to focus in order to extend it again. The result was that the surgeons with the same level of accuracy and precision were 2-3 times faster in the actual operation. This was quite a result that was also demonstrating the need for engaging a specialist, a professional like a surgeon with the high pressure of their work through something that is closer, let's say, to a video game. And this is something I'm going to discuss in a moment. For performing the activities of neuroergonomics, we need ubiquitous sensing, monitoring and analysis. We need to collect several types of data, and we need to do it all time. This is, let's say, this is a set suggested, for instance, by my friend Asana Yats in his laboratory. And an effort we are trying to do is the one to make all the data converge in a holistic representation, a systemic representation of the patient or the user in the case of the other types of technology through a digital twin, a digital replica that in real time can give us even a view of the future of the patient. And in this case, we can see also one of the works I made with my friend Andrea Gaggioli that I need to thank several times for the opportunities to collaborate on these topics. Anyway, managing so much data create also some difficulties in terms of the, let's say, in terms of the values, in terms of ethics, and approaches like the value-sensitive design can help us for trying to find a solution that is respecting, that is protecting the values and the privacy, for instance, of the users and the patients. This one was a result of a project raised I was working on when I was a member of the IIT. We tried to protect, for instance, the users. In this case, it was for a geriatric hospital. That we were monitoring through several wearable and nearable, this is a new term, devices that were adopted for monitoring their level of stress, for instance, and for paying attention to their gaze. And we understood, for instance, that it was quite important and quite helpful to represent them through tunes if we wanted to protect their identity when a PhD student was analyzing the videos of their activity. Obviously, this is a type of solution that should be improved graphically, but it worked quite well for the results of the project. Simultaneously, we understood how it was possible to couple the information at physiological level for detecting the reaction of the person, for instance, the ones related to the anxiety, to the gaze. Gaze is quite a rich source of information because we can know, we can discover what triggered a reaction like the one of a panic attack. And this is quite helpful for people, for the elderly, for people with anxiety, and for people with phobias. Overall, anyway, these devices are quite could be quite expensive, and we need to find solutions that are low cost. Mobile biomarkers, the ones that the set of data we can use, we can, let's say, the set of indices we can derive from the usage of mobile devices are one of the strategies we are exploring in this moment in order to obtain a continuous flow of information for detecting any type of abnormality in the behavior of the person. And neuroergonomics is using this kind of solutions because passive detection is probably the key for obtaining health biomarkers that are reliable and that are rich in terms of the information that can provide for improving our way to treat the problems of the person. And they can derive even from the usage of solution of systems like video games, smartphones, robots, and the wearables. And anyway, through the collection of the data and the analysis of the data from these systems, we don't need to make a specific session. We can collect and we can analyze the condition of the person over the day in a way that is unobtrusive and continuous. Anyway, we are describing something that can be defined like a digitally driven well-being. In my experience, most of the examples I can describe are related to the situation of motor impairment. This was a project I was co-coordinating many years ago. We were trying to create solutions for people with motor neuron disease and people with motor neuron disease in the late stages of their of the progress of their condition, when they were reaching the locked-in syndrome, when they were able to move just the eyes, sometimes neither them. And one of the problems that was a priority according to the medical doctors besides the problems of the communication, was the one of the stress. So we developed several solutions also for entertaining people with such a problem, like creating video games that could be controlled through the gaze, or enabling the visit to a museum. We enabled, for instance, the visit to the Vatican Museum, to the Sistine Chapel, a person with motor neuron disease that was controlling autonomously the robot through the gaze, and also discussing with the guide and with the relatives and other people that were located in the museum, in the Sistine Chapel and in the gallery of Pius VII. This experience was quite intense for all of us. It was quite engaging for the patient. We also were monitoring the level of the change in the heart rate variability, understanding that there was a true engagement of the person. And we were also collecting information about how to improve the control of the device itself. So we were using the museums like an ecologically valid context for validating neuroergonomics hypothesis on the control of these devices, because it was engaging enough to maintain the level of ecological validity we are expecting for this kind of situation, and which is that is something that we cannot obtain in a normal laboratory for sure. Other patients, anyway, were more prone to accept the control of a video game, for especially the younger ones, around 45 as age. And as you can notice, when we wanted to calibrate a neural interface by using a video game, in one of the patients, there was an improvement of the accuracy of classification, in this case, for understanding when the person was figuring out to move the right hand or the left hand. And this was an effort for trying to improve for trying to improve the quality of life of these people, because obviously such a condition that is quite extreme for them can create a huge burden in terms of mental health. Again, another part of our work, sorry for showing always these images, it's almost my presentations, but anyway, using games and using engaging activities, in my opinion, is always the key for trying to improve the matching between the human and the machine, and for solving several problems related to mental health, because actually we have an instinct to play. We are made for playing, because we are made, like all other mammals and the birds, for training by simulation. Through games, through simulations, we are able to test strategies that in real life could be dangerous to try for the first time. This is why all species of mammals and birds play, actually. And we can exploit such kind of instinct, and it's explained through theories like the one of Ryan and the Sea, why they're so engaging, because they can make us feel competent, autonomous, and in relationship with others. They can be used for improving the health of people. This is why I adopted this strategy from the very start of my career in 2006, in the paper on the left on video games for the elderly, and in a more recent paper that was written with another good friend of mine, Massimiliano De Zambotti, that now is working in Aura, a company that is working on wearables. In this case for video game and sleep. Overall, let's say, I don't want to make an excessive medicalization of the digital therapies and the digital all the digital solution for health. Anyway, consider that when we are adding something that is engaging, probably we are obtaining a higher compliance of the user at the point that we are obtaining a better clinical outcome. And I discovered that this type of approach is quite effective, especially when we want to obtain the relaxation in people through virtual reality. For instance, virtual reality is engaging, but we need to go beyond the interaction, the interactivity itself. it's not enough. In this case, we obtained it through a biofeedback that was based on the control of the heart rate variability for adjusting what was happening in a natural setting that was simulated in an immersive environment. And the approaches related to games can be divided into macro areas that are anyway not so split into, probably the borders is fuzzy between them. Serious games, games that are made for serious applications, like the one of helping a person to relax. This was a game made for a person with motor neuron disease, and it was made for enabling a dual control, the one through the gaze for moving a character away from the enemies. But when we proposed this first version, the patient wrote, I want also to attack the enemies, I don't want just to escape. So I had this idea to use the galvanic skin response collected through sensors attached to the fingertips of the patient for enabling this kind of control. The galvanic skin response can be used for detecting the level of stress of the person, and at that point, the game became, the instructions were, move your gaze for escaping from the enemies, but meanwhile, try to relax as much as you can in order to accumulate energy that at a certain point will detonate, trampling all the surrounding enemies. And what we obtained was an inclusive game, because during the events, when we were presenting this solution, all people were playing with the same rules of a person with motor neuron disease. All people were using the same rules. And the other example is the one of the gamification. It's when we are adding game features in something that is absolutely made not for entertainment, like a training system for the surgeons. I use these approaches also for improving the awareness of kids in high school by making them develop games for people with disabilities. This was the Gameability initiative I led in Italy over 6 years. And even in the context of the rehabilitation with multiple sclerosis, in this case, for cognitive rehabilitation, we were using the tangram exercise. The patients were asked to move the tiles for creating some shapes, like a cat, a bunny, a dog, and other animals. It was made for people with multiple sclerosis with cognitive impairments. And they were playing this game in an immersive environment. In some context, anyway, there was a virtual agent, that guy you can see on that sofa, sitting on that sofa, that was interacting with the patient by, in one condition, suggesting some strategies. In other conditions, this virtual agent, this AI, was complaining about the actions of the patient by saying, oh, the other people were faster than you, the other people already finished, you should give up, and so on. And we discovered that the patients that were mistreated by the virtual agent were faster, were getting better, and they were even angrier at the point that in some cases they were throwing the tiles against the virtual agent. Anyway, it was quite an important discovery, because the problem of several solutions we can use in virtual reality is that the lack of engagement can come from the lack of the physical feedback, and we created a social feedback for empowering the sensation. Other solutions can be based on social human-robot interaction, because robots are embodied, and we use them for creating this type of source of engagement. Many people in rehabilitation in multiple sclerosis prefer to use robots, many experts, because robots can elicit more the physical engagement of the person. In my experience, the best solution is to combine them. Combining the usage of exoskeletons, for instance, with mixed reality, in order to make people move virtual objects while they feel the perturbation of or the assistance offered by the exoskeleton. And through this solution, they're able to have a higher level of engagement while they're making activities that are physically challenging, which is quite important for several contexts of motor rehabilitation. This is an example of robotic digital synergy. And this paper, I will mention it again in 2 days during the keynote workshop, because we are going to use the same method I adopted for preparing this investigation, the SWOT analysis. These examples are made for improving, anyway, our integration with the technology. We are using technology that should help people to improve their health conditions, but there is an additional challenge. Sometimes there is a mismatch between us and the technology, and we are creating additional problems. That's why we need to improve, for instance, our presence, the feeling to be there in the virtual context or somewhere else through a robot, in the case of the telepresence, or the embodiment, the feeling that a technological device like an artificial limb is part of their body. This is why the very last part of this presentation is dedicated to the human technology integration and to feeling whole, because a huge part of my work was dedicated to exoskeletons and prosthetic devices. For instance, we are talking about mental well-being. In occupational context, people using exoskeletons can feel a huge stress when they're wearing this kind of device. Why? Because the exoskeleton is made for reducing the physical workload, but actually it's increasing the mental workload, because the person is feeling like a puppet moved by a device. They pay attention to their limbs, they're not paying attention to the task anymore. And I observed the same situation when we are using the exoskeletons for rehabilitation. So we are creating stress in someone that we actually want to help. We are creating mental stress in someone we are helping physically. And we are assuming that the physical help should be enough. Several studies demonstrated that there is a continuum, let's say, in this increase of mental workload. The people with stroke, for instance, are experiencing less mental workload than people with spinal cord injury when they're controlling this, when they're using the same exoskeleton for walking, because people with stroke are still able to move their limbs in a certain level. So they're partially in control. People with spinal cord injury are totally lost their control. I saw patients, for instance, with spinal cord injury, using an exoskeleton by paying attention just to their feet. They were never looking around. They're just paying attention to what is happening to their body. And during the very last study, I conducted at the IIT before moving to Bristol, and then I transferred it, part of it, at the Bristol Robotics Laboratory. I discovered, for instance, that it's quite important to use methodologies like the one of the neuroergonomics for evaluating the mental workload through the gaze, but just focusing on one eye. According to the data I collected, it's just enough to pay attention to the pupil dilation of the right eye. And there is a phenomenon of lateralization in this case that should be explored in depth. And this is one of my priorities in the next months. I worked on the topic of the mental workload, which is quite a key for understanding better problems related to the mental to the stress and to the fatigue of the person in several contexts, like the ones of the prosthetic embodiment. The prosthetic embodiment is the phenomenon of feeling the incorporation of the device in our body. We feel it as part of our body, so we are more prone to use it, to get practice with it. We are also reducing the phantom limb pain in the case of the people, in the case of the amputees. And where I was working at Rehab Technologies Lab in the IIT during the pandemic, I developed this solution that was based on components that can be found at home of anyone. During the pandemic, there was the need expressed by the INAIL, the Health and Safety Institution in Italy, for having a setup that can be created by anyone at home. So my problem was to try to visualize the digital version of the prosthetic limb on a screen, something that anyone can have, producing the vibration that is corresponding to the collision of a ball on the screen with the prosthetic version, or the digital version of the prosthetic limb, through a smartphone that was vibrating under the stump of the patient, or under the hand of the healthy users, the healthy subjects we were involving. while we were detecting the respiratory rate through the microphone of the headphones. And we obtained a biofeedback that was working this way. The patient, the subject was modulating the respiratory rate for visualizing the end of the screen that otherwise would disappear. The respiratory rate was going outside the expected range. And they were feeling the collision of the virtual ball through the vibration of the smartphone just when the hand was fully visualized. What we discovered was that the person, the subject that were testing this system with the slow paced breathing inspired to the mindfulness were feeling the embodiment for the prosthetic limb more than the others that were using a normal pace, a normal breathing rate, 12 breaths per minute. Why? Because as a metric, we were using the proprioceptive drift. We were asking people to close their eyes and to point the position of their limb, or the right limb. And they were pointing at the one on the screen in case they were trained with the slow-paced breathing. And this was due, apparently, according to some studies we are making in this moment and conducted also by other people that got inspiration from this very specific, this very specific experiment. There is probably an involvement of the slow cortical potentials in the brain that are facilitating through the trigger offered by the axis between the breathing rate and the heart rate variability, the multisensory integration. I conducted several other studies in this domain, even trying to use a similar approach through the control of the electromyographic control of a prosthetic limb, a digital version of the limb. In this case, the patient was kicking a digital wall. And in case there was a social condition, we were telling the patients that there was someone else in the metaverse kicking on the same wall. There was a detrimental effect on the embodiment. So we discovered that if people think there is someone else playing with them, the embodiment for the prosthetic limb was decreasing, but the number of kicks was increasing. We increased the engagement. Combining the two solutions, we discovered that the competitive approach, making people compete for destroying the digital wall against someone else, was alternating it with moments in which the person was just destroying it, this wall alone, we were obtaining a better result. Overall, what I wanted to discuss during this presentation is that we should try to facilitate a human-machine integration for healthcare applications by combination the versatility of digital systems with the physical potential of robotic systems. And this could disclose several other ways for improving the human mental health. Just let me tell you that I'm also the chair of this conference in Bristol on telepresence, and we are dedicating a lot of attention on telehealth because I'm the chair specifically for that. And we have a satellite event in Hong Kong. I definitely wanted to have. So please submit papers to our conference because there is a specific session in Hong Kong. Thank you very much.
Thank you. Thank you, Professor Barassi. Actually, it's very inspiring speech you share. Really widened my horizon because I don't know much before your talk. So many terminology that I don't know. Neuroergonomics and digital robotics, digital health, and all this. Actually, I can see a lot of applications that you share with us over the years. Gamified system that apply your technology and also prosthesis and also the exoskeleton. So very inspiring. So does anybody have questions for Professor Bersari? The floor is yours.
Yes. Thank you, Professor Barassi. This is Alice from NU School of Nursing. I'm also doing work on digital mental health using robotics, socially assisted robotics for elderly people. My next step is going to do something on young people because they are under extreme stress studying in Hong Kong. Can you share your future views, how we can apply digital technology for them because they are very difficult to identify. They are at risk, and we are difficult to engage them. Can you share your views?
Yeah, it's a double-edged sword one you're describing, because young people are native in the usage of digital technologies. So sometimes it's also difficult for us to understand how they perceive them, and they can also be more prone to situations like the automation bias. It's when we over rely on the machine, because there is like no border between them and the technology at some time. So exploring strategies for engaging them, it's a paradox. It could be quite easy. It could also be quite dangerous. We need to find a compromise in order to understand in a really precise way what is our goal, what we want to obtain by engaging the young person, in a certain kind of activity that is established according to the corpus of knowledge in the clinical research. So the person should do exactly what is expected by the therapist, by the clinician, but we shouldn't create an excessive let's say, attachment to the device and to the scenario. There is a researcher in Oxford, Professor Przybylski. Przybylski is an expert in the phenomenon of the flow. When we have a deep sense of engagement at the point that we are losing our perception of the time, this is fine, but we need to pay attention to the fact that we need also to study, to work, and to do other activities. I don't mean that all games are addictive, but anything can create an addiction, honestly. Even going to the gym. Even, I mean, an healthy activity could become unhealthy. We need to pay attention and to co-design in particular, because most people here are clinicians. So you're like able to gather all, let's say, decades of experience that are necessary for understanding what are the weak points of the patients and which should be their strongest points. So through the dialogue with you and with the users, so we can understand better how to refine these devices. So my expectations are these, but my expectations should be confirmed or unconfirmed by you.
Thank you. Thank you.
Thank you. Okay. Because of time, I think we can welcome one more question.
I try to be faster anyway than usual, because it was.
Thank you for keeping the time. Thank you. Any other questions? Yes.
So how do you see the integration of artificial intelligence in neuroergonomics?
So again, on how we want to, okay, the user using AI. An AI is able to take decisions. We need to be careful, because the clinical decisions in particular, should always be filtered and should also be guided. Thank you. If you want to consider how the AI can be used for analyzing data, we need to be careful, because the AI, apparently, most AI chatbots are becoming like sycophants sometimes. They tend to confirm the hypothesis of the researcher. And we shouldn't provide an AI, especially offered by a private, with the data of the patients or the users of our technology. So it's important to regulate. Regulation, anyway, should be based on principles like the one of the value-sensitive design. They could derive from empirical studies, from conceptual studies. Investigations is necessary for sure. Anyway, the potential of the AI is enormous, especially because it can enable paradigms like the one of the hybrid intelligence. We know that we can do much more through the AI if we keep considering it as a tool. It's not going to be a partner. During an event in Brussels in December, I remember that there was quite quite a debate about the fact that some people were using terms like human-robot teaming or human AI teaming. The AI is not a teammate. We always need to remember that. Otherwise, we are going to escalate, to make the risk exacerbate in a way that is going to go outside our control. So I'm sorry if I can just say, if I can just mention problems, but we need those problems as constraints for guiding the development. Otherwise, we are wandering around and we risk to be guided by an AI at a certain point to find our way or their way, whatever it is, because we don't know actually. Thank you.
Yeah, thank you so much. Yeah, I think technology is very important. I think you all agree. But the design should be human center. And also the robots or AI should be a tool. Not a tool, but should be our collaborator if you use it wisely. I actually thanks again for Professor Bersari for giving such a visionary roadmap today for us. And also thank you for all your participation and all your engagement and your insightful question being raised. So a big round of applause to Professor Bersari. Thank you.